This is Stephanie Huff, and I'm recording a concept on cellular regulation. This goes along with the perfusion lecture. This one is on anemia, just an overview of anemia. When you're talking about anemia, this occurs when oxygen delivery is inadequate. And there are several different things that can cause this, but your red blood cells are your oxygen-carrying cells. And the oxygen does bind with the hemoglobin, and that's what carries the oxygen throughout the body. So when you have anemia, you can have a deficient volume of healthy red blood cells, and so if you don't have enough healthy red blood cells, then you don't have as much oxygen delivering capacity. This could be related to blood loss, inadequate production of red blood cells, or an increased red blood cell destruction. Another process that can cause oxygen delivery to be inadequate is a decreased normal hemoglobin. This is usually related to some type of nutritional deficiency or physiological disorders. And so there's a slide just showing you the difference between normal red blood cells and those of somebody with anemia. Looking at the pathophysiology, all types of anemia will reduce the oxygen carrying capacity of the blood. This can lead to hypoxia. If anemia is slow in onset, then the body can compensate. If it happens very abruptly, then the body does not have that ability to compensate as well. Looking at your etiology, iron deficiency anemia is going to be your most common type. It's not usually from an inadequate dietary intake in the United States, but usually it's from a chronic bleeding or occult blood loss, which is a hidden blood loss, and that could be from a bleeding peptic ulcer, some type of gastrointestinal inflammation, or it could be from hemorrhoids that are bleeding. Pica is also a cause for iron deficiency anemia, and that is basically someone that is eating foods that have no nutritional value, or eating things that are not really food. Probably one of your most common ones around here, just because we're living in the South, is eating of white dirt, and that will cause them to be anemic, and they're not having any blood loss. It's just because of the white dirt. All right, another type of anemia is vitamin B12 deficiency anemia. Which can be prevented with eggs, cheese, milk, meat, and fortified cereals. Some of your risk factors for developing anemia is going to be poor nutrition. They should be on a well-balanced diet that is rich in fresh fruits and vegetables. Menstruation can cause a significant amount of blood loss. Prevention, some are genetic and cannot be prevented. Adequate nutrition can prevent other types of anemia, and since iron deficiency anemia is your most common, they need to make sure that they have a balanced diet and iron-rich foods with vegetables, fruits, whole grains, low-fat milk products, eggs, lean meat, and fish. Legumes, those are your lentils and certain types of peas and beans, and they are also high in iron. Your clinical manifestations are going to be categorized by their cause. So you've got blood loss as being a cause. You've also got nutritional factors as a cause. Hemolytic, bone marrow suppression. And each type has specific pathophysiology and manifestations, and we'll go through those here on the next few slides. So your blood loss anemia, bleeding causes the loss of red blood cells, and other blood components. Acute blood loss, this is when the circulating red blood cells of normal size and shape, normal shape is also known as normocytic. Eventually there will be a deficiency in red blood cells and their hemoglobin and hematocrit. If the bleeding is stopped, then the body will rebuild these blood cells in about 3 to 4 weeks' time. For your chronic blood loss, this is from depleted iron stores. It could also be from the red blood cells being small, which is microcytic. If they're large, it's macrocytic, but these are microcytic, and they're pale, so they don't have as much color, so they're hypochromic. Your clinical manifestations are going to depend on the amount of blood that was lost and if it's acute or chronic. So some of your acute blood loss manifestations, they will have a compensatory mechanism of an increased heart rate and constriction of peripheral blood vessels. If they are hemorrhaging and this continues, the compensatory mechanisms will start to fail. They will be at increased risk for hypovolemic shock, which would give them the signs and symptoms of tachycardia, tachypnea. Skin will be cool, pale, and clammy. They may end up with circulatory failure. Eventually they will have hypotension, increased tachycardia, a decrease in their level of consciousness, and oliguria. You may often hear a systolic heart murmur as well. When you're looking at nutritional anemias, one is iron deficiency anemia, which we talked a little bit about. And remember, this is your most common form. For chronic iron deficiency anemia, this will lead to brittle, spoon-shaped nails, cheilitis, which is cracks in the corner of the mouth that can bleed. They usually have a smooth, sore tongue and may also have pica. So in iron deficiency anemia, when the body supply of iron is inadequate for optimal red blood cell formation, this results in fewer number of red blood cells and in microcytic, hypochromic, and malformed red blood cells, which is also called poikilocytosis. Vitamin B12 deficiency anemia is another type of nutritional anemia. The manifestations usually develop gradually. Some of their manifestations will include pallor, slight jaundice, and weakness. This may progress to paresthesia, which is numbness and tingling, problems with proprioception, and that's the sense of one's position in space. A lot of times they have difficulty maintaining a balance as a result of spinal cord damage, which could be a causative factor. So vitamin B12 is found in almost exclusively in foods that are derived from animals. So vitamin B12 anemia occurs when intake of inadequate, or more commonly when it's poorly absorbed from the GI tract, and they end up with large misshapen immature red blood cells. And so on your pictures over here, I've given you some examples of foods that are high in B12, and then just looking at the pallor and the glossitis, which is that smooth sore tongue that you'll see in iron deficiency anemia. All right, pernicious anemia is another nutritional anemia. Pernicious anemia also deals with a lack of vitamin B12, but in pernicious anemia, This is when the body has a failure to absorb vitamin B12. And this develops from a lack of the gastric intrinsic factor, which is the substance excreted by the gastric mucosa. This intrinsic factor will bind with vitamin B12, and it travels with it into the ileum where it is absorbed. So people that have pernicious anemia, it could be from a resection of the stomach or the ileum. It could also be from loss of pancreatic secretions and from chronic gastritis. And so a lot of your people that have gastric bypass type surgeries, they're at increased risk for pernicious anemia, because a lot of times they will take out that part that has the intrinsic factor in it, so they're not able to absorb the vitamin B12 because there's no intrinsic factor to bind to it. Your manifestations of pernicious anemia are going to be diarrhea, smooth, sore, beefy red tongue, so it's kind of going to look a lot like it did with your iron deficiency anemia. Your folic acid deficiency anemia. This results from an inadequate intake. It is more common in people with chronic undernourishment. These will be people that have alcohol and drug addictions. Alcohol is especially related to folic acid deficiency anemia because it suppresses the folate metabolism. Your pregnant females may need folic acid supplements to promote fetal development because your neural tube defects, especially meningomyocele, are common due to a folic acid deficiency. People with celiac sprue are at risk for this type of anemia. Other causes are going to be some of your drugs like methotrexate, some of your chemotherapy drugs, and anticonvulsants. So manifestations for folic acid deficiency anemia will develop gradually. They will have pallor, progressive weakness and fatigue, shortness of breath, palpitations. Others manifestations that you'll see with folic acid deficiency anemia are similar to vitamin B12 anemia, and that will be the glossitis, chilicis, which is the cracks in the corner of the mouth. Diarrhea is also common. And so this picture shows you the stomach and basically where the intrinsic factor is and how there's a lack of it. And then the bottom picture just shows you some of your foods that are rich in folic acid. Your hemolytic anemias. The first one we're going to talk about is thalassemia. Thalassemia refers to an inherited disorder of hemoglobin synthesis where either alpha or beta chains of the hemoglobin are missing or defective. Thalassemia is more prevalent in your Mediterranean descents, so that's like southern Italy and Greece. And those are more common with the beta defect. Your Asians like Thailand, Philippines, and China are more prone to have the alpha defect. Your Africans and African Americans can have both beta and alpha defects. Children with thalassemia will require major blood transfusions throughout their life, so they are at risk for iron overload. Patients with thalassemia minor are usually asymptomatic, but patients that have thalassemia major, they will have some of the symptoms that we'll talk about here in just a second, and that is anemia, splenomegaly, so an enlarged spleen. Their skin will be bronze in color, and they will also have bone marrow hyperplasia. And these symptoms can be mild to moderate. Thalassemia major form causes severe anemia, heart failure, liver and spleen enlargement, jaundice. They will be prone to fractures of long bones, ribs, vertebrae, and that's from bone marrow expansion and thinning. Your acquired hemolytic anemia is caused by hemolysis from factors outside of the red blood cells. So your causes are going to be mechanical trauma to the red blood cells, from prosthetic heart valves, could be from severe burns, hemodialysis, radiation, autoimmune disorders, bacterial or protozoa infections, transfusion reactions, drugs, toxins, chemical agents, or venoms. Their acquired hemolytic anemia can be mild to moderate anemia. Some of your symptoms that you'll see is an enlarged spleen, and that's because the spleen is removing those damaged and destroyed red blood cells. You will also see jaundice, bone deformities, and pathological fractures with acquired hemolytic anemia. In your G6PD, that is a glucose 6-phosphate dehydrogenase anemia. So the G6PD is a lot easier to say. And this is caused by a hereditary defect in red blood cell metabolism. It is common in African and Mediterranean descent. Hemolysis occurs when they are exposed to stressors. That could be drugs like aspirin, sulfonamides, or vitamin K. It impairs the compensatory mechanisms of increase in glucose metabolism and causes cellular damage. Alright, so in your G6PD, the symptoms will occur when they, within several days after the stressor, and so they'll have pallor, jaundice, hemoglobinuria, and an increased reticulocyte count. Once the new red blood cells develop, then their counts will return to normal. And so this bottom picture just shows you the thalassemia, which normal blood cells, and then the ones that get malformed. Like I said, it is an inherited disorder, and so if both parents carry normal or healthy genes, then they'll have healthy children. If one of the parents has an affected hemoglobin gene, then they are a carrier for thalassemia, and half of their kids will be healthy and the other half will have the trait. If both parents carry the thalassemia trait, then you'll have 25% will be have thalassemia, half will have the trait, and another 25% will be healthy. So those are basically the risk for the transmission to children. Alright, so this is a slide looking at the G6PD deficiency. And so this is kind of showing you how these red blood cells can get damaged, and talking about how it's usually self-limited and the red blood cells are replaced, but it also gives you your exposures and stressors that can cause this deficiency. Alright, looking at aplastic anemia. This is when the bone marrow fails to produce all three types of blood cells. This leads to pancytopenia, which is a deficiency in red and white blood cells. Normal bone marrow is replaced by fat. This type of anemia is rare. Symptoms vary with severity of the pancytopenia. The onset is usually insidious, but it may be sudden. So it could be a gradual onset or it could be very sudden. Your signs and symptoms are going to be fatigue, pallor, a progressive weakness, exertional dyspnea, headache, tachycardia. They may also have heart failure, platelet deficiency can lead to bleeding problems. So you want to assess their gums for bleeding, look for excessive bruising and epistaxis, which is nosebleeds. They will have a decrease in their white blood cell count, so this puts them at an increased risk for infection. And your Fanconi anemia, this is a rare form of aplastic anemia. It is caused by defects of the DNA repair. 50% of the people with this type, the cause is unknown, so it's an idiopathic aplastic anemia. Other causes following stem cell damage caused by exposure to radiation or certain chemical substances, such as arsenic, benzene, pesticides, certain antibiotics. Chloramphenicol is one of the antibiotics that can cause this. Your chemotherapy drugs. It also can occur after or with a viral infection like hepatitis and HIV disease. Alright, so this is looking at that Fanconi anemia, and they often will have strabismus. Their stature will be short, their ears are low set, they usually have frequent infections in their ears, may even lead to deafness. They usually have abnormal thumbs, so they may not have a thumb at all. They may have two thumbs. They also have a hypopigmentation and freckles. Alright, so your lifespan considerations. Neonatal anemia is caused by blood loss. This occurs in utero from placental bleeding, like from placental previa or abruptio placenta. It can also be from birth trauma to the abdominal organs. The adrenal glands can actually be damaged and start hemorrhaging. They can also have damage to the cranium, and they can have a subgaleal bleed, which is the space between the skull and the scalp. Alright, they will have hemolysis and erythrocyte destruction. This is usually from blood group incompatibilities, but could be from infections as well. Most common is genetically transmitted deficiency of G6PD, but it could also be related to an impaired red blood cell production. Your physiologic anemia of infancy occurs as a result of gradual drop in hemoglobin for the first 6 to 12 weeks of life. This is when the hemoglobin decreases in term infants. The bone marrow begins production of red blood cells again, and the anemia will disappear. So this is just kind of one of those things that automatically happens, and the body just kind of takes care of itself. Alright, looking at collaboration. Your priority is to ensure adequate tissue oxygenation. Specific therapy determined by the underlying cause of the anemia. So in nutritional anemias, these are addressed through dietary counseling. Some anemias are going to be treated with medications, and in severe cases, blood transfusions are going to be needed. So your diagnostic test, your CBC is going to measure your red blood cells, also looks at your hemoglobin and hematocrit levels. You want to look at serum iron levels. A microscopic analysis is done as well. Schilling test, bone marrow examination. a quantitative assay of G6PD. You also want to get a diet history and analysis. This will give information on their food intake. Surgeries. You want to identify and repair organs or tissues that are the source of blood loss. Aplastic anemia may require stem cell transplant, which is the same thing as a bone marrow transplant for damaged bone marrow. And pernicious anemia, which is your vitamin B12 anemia, may require surgical exploration to assess the causative factor, whether it's celiac disease, Crohn's disease, diverticulitis. All of these are known to decrease the intrinsic factor as well. Thalassemia major may need a splenectomy. Pharmacologic therapy is going to depend on the underlying cause. So some of your drugs that they're going to use is ferrous sulfate or other iron sources. For symptomatic iron deficiency anemia that does not respond to dietary modifications alone, they can do supplemental iron. It can be given orally or parenterally. IV and IM iron are becoming more common. Critical side effects of parenteral iron range from hypersensitivity reactions to anaphylaxis. So you must closely monitor these patients for an adverse reaction. Oral iron side effects are going to be constipation, nausea, heartburn, and a lot of times it makes their stools black and tarry, but that's an education thing, because it'll look like that they've got blood in their stool, but it's really from the iron. So it would not test positive if you tested it on a Hemocult slide. Your folic acid is given to females of childbearing age, pregnant women, and patients with folic acid deficiency or sickle cell disease to meet the increased demands of the bone marrow. Hydroxyurea is also given. This promotes fetal hemoglobin production. It may be prescribed for patients with sickle cell disease, especially those that have frequent crises or they have a severe disease. Once they give the hydroxyurea, this results in increased levels of fetal hemoglobin. This interferes with the sickling process and reduces the incidence of painful crisis. And we'll talk about that more a little bit later. Your prenatal vitamin B12 is given when malabsorption, parental, not prenatal, parental vitamin B12 is given when malabsorption or the lack of intrinsic factor leads to a vitamin B12 deficiency anemia. And so a lot of times, probably the most common is the B12 injections. Alright, so your erythropoietin, this is ordered for patients with a low erythropoietin level. That could be from chronic renal failure. And for those with anemia from other chronic diseases, it is given sub-Q as often as 3 times a week for chronic renal failure. And because erythropoietin stimulates red blood cell production, adequate iron must be present. So they may require an IV iron therapy as well as the erythropoietin. So those are commonly given together. Your immunosuppressive therapy with anti-thymocyte globulin, corticosteroids, and cyclosporin is used to treat aplastic anemia. Your androgens stimulate blood cell production and is sometimes used in your patients with aplastic anemia as well. So non-pharmacologic therapy. Diet modifications for nutritional deficiency anemia. So sources of your heme iron is going to be beef, chicken, egg yolk, clams, oysters, pork loins, turkey, and veal. Sources of your non-heme iron are going to be bran flakes, brown rice, whole grain breads, dried beans, dried fruits, greens, oatmeal. Your sources of folic acid are going to be green leafy vegetables, broccoli, organ meats, eggs, wheat germ, asparagus, milk, yeast, and kidney beans. Sources of vitamin B12 are liver, fresh shrimp and oysters, eggs, milk, kidney, meats, and it's really the muscle meats, and cheese. Other non-pharmacologic therapies, blood transfusions may be required for anemias from major blood loss. This could be from trauma or major surgery, and severe anemia regardless of the cause. So those that have cardiovascular instability or compromise may need blood transfusions. In aplastic anemia, this may lead blood transfusions as well. Your thalassaemic patients will get blood transfusions throughout their lifespan. Looking at the nursing process, you want to screen your clients that are at risk for anemia to promote early intervention and prevent complications. Long-term care for the client with anemia will center around prevention of complications and optimization of health and wellness. Client teaching is directed towards self-care and will often include dietary counseling. So looking at this assessment in your health history, a lot of times they will complain of shortness of breath, especially with activity, fatigue, weakness, dizziness, or fainting, may have palpitations, history of anemia that they had previously, or any bleeding episodes, their menstrual history, and that looks at how heavy their menstrual cycle is, how many days do they are they on their cycle, their current medications, chronic diseases that they have, their usual diet, alcohol intake, and smoking history. All right, looking at the physical examination, you want to assess their general appearance, look at their skin color, their vital signs including temperature, assessing heart and lung sounds, assessing peripheral pulses, capillary refill, assessing for any abdominal tenderness, any obvious bleeding or bruising. These are your NANDA diagnosis for anemia. All right, in planning, some of your goals may include that the client will report an absence of dyspnea. They will verbalize awareness of signs and symptoms of exacerbations. They will describe a plan for balancing activity and rest, and that will help maintain some of their energy and decrease oxygen demand. Make dietary choices to increase iron intake. Demonstrate appropriate self-administration of supplements. They will also maintain the red blood cell count within a specified acceptable range. In implementation, nursing interventions may include promoting optimal cardiorespiratory function. In this, they will monitor vital signs, breath sounds. Increased cardiac workload can affect blood pressure, heart, and respiratory rates. Monitor their apical pulse. And increased blood flow can lead to heart murmurs or abnormal sounds like your S3s and S4s. You want to assess for pallor, cyanosis, and dependent edema. A lot of times blood is shunted to the vital organs to protect them and away from the periphery, so that causes vasoconstriction, and so this with a decreased hemoglobin will give them a pallor color. Cyanosis, especially of the lips and nail beds, signifies an inadequate oxygenation of the blood. Dependent edema occurs with right-sided heart failure. You also want to closely monitor for anaphylaxis when administering parenteral iron preparations. And that will give you symptoms of urticaria, erythema or flushing, edema, wheezing, dyspnea, nausea, vomiting, and anxiety. This can lead to severe cardiopulmonary compromise. If anaphylactic occurs, you want to stop the iron transfusion immediately, notify the physician, and prepare to give epinephrine, Benadryl. They may need CPR. A lot of times they'll use corticosteroids as well. You want to promote a balance between oxygen supply and demand. In order to do this, you want to help identify ways to conserve energy when doing activities so they can sit to perform hygiene or to do kitchen tasks like cooking or cutting up food. They can also get help from other people in their household. You want to help the client and family establish priorities for tasks and activities. Assist to develop a schedule for alternating periods of rest and activities, encouraging 8 to 10 hours of sleep at night. Rest decreases oxygen demand and conserves energy for use for the next day. You want to monitor vital signs before and after activity. Any changes in blood pressure, increased heart or respiratory rates indicates an intolerance to the activity. You want to discontinue activity with symptoms such as chest pain, breathlessness, vertigo, palpitations, or tachycardia that doesn't return to normal after 4 minutes of rest. Your bradycardia, tachypnea, or dyspnea. They can also have decreased systolic blood pressure. So if any of those signs and symptoms occur, then they need to discontinue activity and rest. If the client smokes, you want to encourage them to stop smoking. Smoking does cause vasoconstriction, and it increases carbon monoxide levels in the body. And carbon monoxide binds more readily to your hemoglobin than oxygen does, and they already have a decreased hemoglobin circulation, decreased red blood cells, and so you want the few that are in there to bind with oxygen and not your carbon monoxide. And so vasoconstriction and this increased carbon monoxide in the blood both interfere with tissue oxygenation. All right, facilitating enhanced self-care. They may need some assistance with their activities of daily living. You want to monitor their lips and tongue for glossitis, which is inflammation of the tongue, which you will see in deficiencies with iron, folate, and vitamin B12. Also see this cheilitis, which is the cracks in the corner of their mouth. That increases the risk of bleeding and infection. Pain may also interfere with their nutritional status, and that's just related to the pain in the corners and those cracks in the corners, as well as the glossitis. And so they may have a decreased oral intake. You want to use mouthwash every 2 to 4 hours with saline, salt water, or half-strength peroxide in water. And this will help cleanse and soothe the oral mucous membranes. Alcohol-based mouthwashes will further irritate and dry the oral tissue, so it should be avoided. Providing frequent oral hygiene with use of soft bristle toothbrushes or sponges. Apply a petroleum-based lubricating jelly or ointment to the lips to help moisten and protect the lips. You want to encourage soft, cool, bland foods. This will promote comfort and maintain adequate food and fluid intake. You want to avoid hot, spicy, acidic foods. These will further irritate and dry the mucous membranes. You want to encourage the client to eat 4 to 6 small, high-protein, high-vitamin meals per day. So these small, frequent meals are usually much better tolerated and helps preserve their energy. Evaluation. Some of your expected outcomes may include the client's red blood cell count and hemoglobin levels are within normal limits. Client and family members verbalize understanding of their treatment regimen. Client will continue to recommend dietary intake of iron. Client will be free from side effects of iron therapy. Client will be active and able to maintain normal activities, and pediatric client will achieve appropriate growth and developmental milestones. So this is the end of the lecture on anemia, and as always, if you have questions, let me know and I will try to help clarify.